Good evening, friends. Welcome to the Tuesday evening critical care programs. This has been almost a fourth to fifth year. We have been continuously trying to bring the topics of all of your interest and bringing some interest in among all the critical care fraternity. Today, we are bringing some hematological emergencies which are not uncommon in many of our practice with experts in both hemato-oncology and BMT. So I first invite Dr. K. Ashok Kumar sir, who is a senior consultant hemato-oncologist and BMT physician from Yashoda Hospitals, Somajigoda. Thank you, Dr. Ashok Kumar sir, for being here and being a part of it. Thank you for your presence and time, sir.
Thank you very much, sir, for the kind invitation.
I also invite our head of the department and senior consultant in Somajigoda Yashoda Hospitals, Dr. Karthik Munta. He has been a part of many academic sessions previously, and again today he was actively involved in this case and heading the department. So I invite Dr. Karthik Munta to be a part of this program. Karthik, welcome you.
Thank you, sir. Thank you.
And today we have our speaker, Dr. Avdesh Pratap, who is a senior consultant being in the critical care medicine for maybe more than a decade or so, carrying a vast experience both in India and abroad. And he was a part of Yashoda Hospitals, Somajigoda for the last 3-4 months. So even though he's new to this organization, but he was a very senior colleague and a friend of many of us from maybe a decade or so. Dr. Avdesh will take us through a topic which is a very common scenario in many of our intensive care unit, that is TTP. And these TMA disorders are not uncommon in many of us. When we see a patient having tetrad, pentads, or a part of it in the form of you having a Adams TS13 levels lowering because of many autoantibodies causing rise in microthrombies due to probably von Willebrand factor aggregations in a manifold, and that leading to causing a microthrombi in a different segments including the organs, causing organ dysfunctions, consumption of coagulation parameters, and maybe consumption of platelets and many. So TTP is a spectrum. We see TTP, HUS, and many more spectrum. And nowadays, we also are evaluating them on sending Adams TS13 levels, and aggressive treatment and identification of them in an early actually gives us survival benefits. With this, I request Dr. Avdesh to bring a case. I request Dr. Karthik to actually moderate the session as he was being a part of this case. So he will take us through how they evaluated, how they started from a suspicion and then diagnosis and made the patient a survivor. And we all know if TTP is missed in the early part, the mortality can be as high as maybe 50%, 70% or higher. So how did they actually run through? This is a live case happened in last few weeks of Yashoda Hospitals from Somajigoda. So I invite the whole team members to actually get involved. Over to you, Dr. Avdesh, for your case.
Thank you, sir, for your kind introduction and giving a brief about the case scenario. So today's topic is TTP hematological emergency. Why it is from suspicion to survival? Because any disease in the diagnosis and therapeutic intervention or from the deviation from the standard care increases progression of multi-organ involvement and increases mortality. As for brain, time is brain, and for the cardiac part, time is muscles. For few diseases like TTP, time is life. So this is a real case which we dealt few days back. So a 17-year-old girl presented to the outside hospital with complaint of facial swelling on 24th of December, continuous high-grade fever since 25th, and history of giddiness and fall on 27th of the December, taken to a local hospital where she was managed with supportive care and remained she was hemodynamically stable, and she doesn't have any comorbids. Labs value during the hospital course were on dated 27th when she presented to the hospital, found to have anemia, severe anemia, thrombocytopenia, and leukopenia. It's a pancytopenia picture with AKI, component of AKI, and mildly increased in the bilirubin. On 28th, she follows the same course. They repeated the labs, but continued to be having pancytopenic with worsening creatinine. On 29th, again, she was remaining anemic, leukopenic, thrombocytopenic, and creatinine again in the increasing trend. So in view of severe anemia, they transfused 2 units of PRBC, and she was having a severe thrombocytopenia again on the repeated value of 10,000. They transfused one SDP in a hospital and other SDP on the way. On 30th, the pictures were 4.45200, 0.36, 36,000, and INR they did. It's found out to be normal, and they did the LDH was reported to be 750. And she was in having menses, second day of the menses on 29th of December. During the hospital noted to have pancytopenia, worsening renal injury, mild increase in the bilirubin. On 29th December, she started to have confusion, irrelevant speech, decreased responsiveness. Despite their intervention and the management, patient continues to have deteriorating condition and shifted to a higher center. On arrival, that is on the 31st of the early morning, was having irritability in the ED when she was assessed, irritability, restlessness, GCS of around 10/15 with components of E3, V2, M5. But she was having patent airway, febrile, mildly tachypneic, requiring oxygen, tachycardic up to 130 per minute, but stable blood pressure. Labs was ordered. Tropical workup also done in view of thrombocytopenia and other things on that, but the INRs remains the same, and cultures ordered. In view of her low GCS and the tachycardia component, CT brain was done, which was found to be normal. 2D echo was done. That's also be normal, apart from the tachycardia they noted during the study. And the USG abdomen, which shows mild hepatosplenomegaly, GB edema, grade 1 renal parenchymal diseases, mild to moderate ascites, and with bilateral pleural effusions. So at this point of time, I will likely to invite Dr. Karthik for, based on the conditions, based on the lab values, what we have and the clinical scenario, what will be the probable diagnosis and differentials, and any other specific investigation want to order till we have the labs in our hand. Over to Dr. Karthik.
Yeah, so this is a very interesting case. On an evening, we had received this case from ER in intubated state. So the ER physician had called up saying that patient needed ventilation because of threatened airway, and patient had a pancytopenia kind of picture and had multi-organ involvement, and she was brought to ICU from ER on ventilator support. So whenever we see patients with multi-organ problems coming with pancytopenia picture, there are many things that go in your brain. The intention of bringing this case today for discussion is to have a high degree of suspicion when you find such cases. So you might be distracted towards an infectious etiology, or you might be distracted towards if this patient is not a pregnant patient, but a pregnant patient can also present in certain conditions, and patient might have infectious conditions landing up with disseminated intravascular coagulation, which might mimic the similar kind of picture. But here in this scenario, when we are seeing the clinical background situation, what happened or what transpired in outside hospital, and what came with what complaint she came to our hospital, to our ICU, certainly there are some differentials that you would consider. We'll come to the picture of thrombotic thrombocytopenic purpura a bit later, but what would be my differentials in this patient would be like sepsis, definitely infectious etiology. You can have conditions like malaria, babesiosis, which can mimic this kind of condition. They can be conditioned like a disseminated intravascular coagulation due to sepsis or due to any other etiology. But the one thing that differentiates your disseminated intravascular coagulation from TTP is that there is no coagulation derangement in TTP. So usually coagulation parameters, PT, INR, they are deranged in a DIC kind of picture, whereas they are not in form of TTP. Then the third thing that will come to your mind is something like an autoimmune hemolytic anemia. So you might have a warm autoimmune hemolytic anemia, where we would have autoimmune bodies, something like Coombs test positive. We'll come to this case where we had direct test positive, but usually they are not having Coombs test positive in TTP. So these are like some of the differentials that we have in our mind when we are encountering such a situation. Amongst all these things, there are some features which are telltale signs, like worsening creatinine, presentation of your neurological symptoms. This patient had altered sensorium, and GCS was bad, and there was no proper clarity or explanation to why her GCS was bad. Her CT brain was normal, and tropical fever also was suspected, and a patient had mild hepatosplenomegaly, GB edema, so there is a possibility of dengue. So we had sent those tests also for tropical fever, which later came out to be negative. So these are some of the differentials that were in our mind, and amongst them, when we saw that the coagulation parameters were normal with thrombocytopenia, with anemia, with neurological presentation, and patient having later on, I think Dr. Avdesh will take you to the course where we had cystocytes in the peripheral smear. We had rise in indirect bilirubin levels suggesting hemolysis, and we had lactate dehydrogenase test also coming high. So all these point towards an aspect of hemolytic picture with acute kidney injury as well as neurological manifestation, which are like signs of pentad. Like we say that the incidence of pentad presentation with TTP is less than 10%. So this was one of those cases where all the classical signs of TTP were there. So these are some of the things that clinical suspicion is very important. The purpose why this case is being projected today is to have that clinical suspicion whenever you're dealing with the situation, and high suspicion only will raise the bells or ring the alarm, and then will propagate you towards diagnosis and then the therapeutic intervention at a timely fashion. So these are some of the opinions that I had about the differentials in this case.
So yes, you rightly said, Karthik, because that's the spectrum is thrombotic microangiopathy, and it's presented with the wide spectrums, typical, atypical HUS. Any rheumatological disease can present that. When malignant hypertension can precipitate, drugs can precipitate, metabolism, and DIC, which is sometimes difficult to differentiate, will come on that part. And even in the transplantation related TMA and cancer related bone marrow or after a bone marrow transplant. And this one is the thrombotic thrombocytopenic purpura, which is having a very high mortality if not treated on the time. So there is some point which commonly shares between DIC and TMA. Actually, it's a picture of MAHA, where TMA and DIC are the components of it. When you see the TMA here, it's MAHA, it's TMA, it's include more of the components of TMA, microthrombotic, organ failure. They are more common in the organ failure in the TMA in early presentation. And definitely both are having thrombocytopenia. The DIC depends on what is the trigger for that, and they have the markedly elevated fibrin related products or markers, which is usually normal in the TMA. And one of the clinical future differentiate test laboratory feature is the normal coagulation profile. The normal coagulation, it remains normal in the TMA usually, and especially in the TTP. And how it differs from the pathology point of view, TMA and DIC. So there is a common injury leads to the vascular or endothelial cell injury. But what is the trigger? Trigger is the different. Here is the platelet activation in the TMA, and the DIC, it's a coagulation system activation. As we know, coagulation system activation is done by endotoxin infections and inflammatory cytokines, non-infective, and the tumor related, which leading to fibrinolysis and DIC. Whereas in the TMA, adenosine deficiency or and complemented activated complement system like in HUS and the sugar toxin presentation. So now when we have a high suspicion of TTP or TMA, especially with the TMA with the TTP, we go for the plasmic scores. So how it helps and when to use the plasmic score. When you have a very high suspicion of TTP, plasmic score help you to reach an early presumptive diagnosis. And how it helps, it's correlate with the activity of the Adams 13 activity. So you will able to know earlier beforehand, because Adams 13 activity will take 3 to 5 days to be, it's a turnaround time. So you can't wait till then, because here in TTP, time is the life. So we find out to be having plasmic score for our patient is 6. Based on that plasmic score, because we'll come to the plasmic score next slide. So high dose of steroid was given and FFP transfusion was advised. So plasmic score is the tool which rapidly assesses the likelihood of severe Adams deficiency to make a presumptive diagnosis of TTP, guiding the urgent treatment decisions. It leads to the urgent treatment decision. So components of plasmic score are platelets, hemolysis, absence of cancer. Each component is given one number. Any number above 5 or more than 5 having a high probability of Adams 13 deficiency, especially when they have high risk of 6 to 7 points. The deficiency probability of less than 10 is around 60 to 80% or more than that sometimes. And what they say, if Adams 13, you can correlate with the points. If it is 6 or more than 6, it's usually 100% specific for that one. So clinical utilities enables the rapid bedside assessment while awaiting the Adams 13 results to fasten the therapeutic procedure or intervention. So as a theoretical, they say score if more than 5, anything more than equal to 5 or 5 warrants the urgent plasma exchange initiation. So why it is an hematological
one discussion we would have here, Avdesh. I just wanted to interrupt you. Sorry for that.
No.
Sir, Ashok sir, I just had one question to ask, sir.
Yes, sir.
Here, especially when we are seeing plasmic score and we are equating the score, plasmic score to severity of Adams 13 deficiency. So do we have to wait for the Adams 13 deficiency, or we go ahead and we go ahead for plasma exchange if our score falls under high risk?
Sir, nowadays we are not, previously when this plasmic score is not there before 2017, sir. And before that, we used to have a score called French scoring system for TTP. There is only two points. One, thrombocytopenia less than 30. And the other one is this creatinine less than 2.2. Each has a scoring of 1. If there is 0, less chance. 1 is there is some chance of TTP, and 2 is there is high chance of TTP. Even before that, classical teaching is clinical picture is most important, sir. Based on the history presenting with fever, altered sensorium, with microangiopathic hemolytic anemia and thrombocytopenia, diet comes negative, normal coagulation parameters. If these are there and raised LDH, and we should always request our pathologist to look the peripheral smear for cystocytes. That's what we have done in this case, sir. The next day morning, we requested our pathologist to look for cystocytes. On the day, on night she came, we can't ask a pathologist at that time. So morning when we came, we requested our pathologist to look for cystocytes. If cystocytes are there means, and after meeting all these pentad criteria, definitely then there is no point in doing plasmic score, French score, Adam test, that inactivity, nothing, sir. Immediately we had to start plasma exchange. At least you have to give plasma infusion. But one thing I want to emphasize here is platelets should never be given if you suspect a case of TTP. That's an absolute contraindication to give platelets. This patient unfortunately received 2 SDPs, one in their nearby village and the other one in Karimnagar. Then they came here. By that time she landed here, she developed altered sensor. All this because already there is a lot of microthrombi is forming, and once you give these platelets will increase the thrombi and leading to a massive myocardial infarction or massive cerebral infarction, which is the ultimate cause of death in these patients. Cause of death in TTP is either massive MI or massive cerebral infarction. So once you have a differential diagnosis of TTP, it's better to start plasma exchange. If you want to buy some time, at least give plasma infusion. That's what we have done. Overnight, we gave 4 units of FFP in this case, not platelets. And then in the morning, after a discussion with the family and then giving consent, all those things, then we have initiated a plasma exchange, sir. So there is no need to score. Is all theoretical, sir, but practically when you are in ER or in the ICU, you may do all these things. You may get point in exam point of view, like theoretically you can speak all these things, but clinically, whenever you meet this pentad criteria, along with presence of cystocytes in the peripheral blood, you have immediately start plasma exchange, sir. No need for wait for at the Adam TS13 activity, because when we are doing our PG, the Adam TS13 activity takes 1 month of time for the report to come. We used to send samples to CMC Vellore. That's the only center doing Adam TS13 activity. We can't wait. By that time, patient will die, sir, because
So one add-on point to that is the textbooks or teaching says that the Adams levels, especially if you are talking about TTP, autoimmune etiology, TTP, classical TTP is usually less than 10%. But the other variants of TTP, etiology-wise, if you say non-immune kinds of TTP, those don't have that low enzyme deficiency. Doesn't plasmic score help us in differentiating that? Because
no, sir.
therapeutic
No, sir.
plasma exchange, will it differ in the
There we don't do plasma exchange itself. For example, in drug-induced TTP, like we commonly use cyclosporine, that itself is a precipitates TTP in some patients, very few patients, sir. Just stop cyclosporine and go for alternative immune suppression, like sirolimus or TAC, like that. And in pregnancy and congenital TTP, or in HIV-associated TTP, in some drugs like quinine and other statins, there is nothing to do with Adams TS13 activity. It is only just because of the precipitating factor, underlying cause, sir. If you treat that underlying cause, then it will be cured. So the plasmic score will not play a major role in those settings, sir.
Okay, sir. Yeah, Avdesh, you can continue.
So correctly, as Dr. Ashok sir said, it's like plasma exchange required for TTP. So why it's an emergency? Because without treatment, mortality increases to more than 90%. Even with treatment, though it is very low, but it's still 10 to 20% mortality is still there despite the treatment. So in our case, the patient was having hemolytic anemia, thrombocytopenia, fever, neurological and renal dysfunction, which is what we called as an pentad, and presence of cystocytes, plasmic score. So there is very high probability of TTP in this part, and based on that clinical, laboratorical, and the scoring basis, we started therapeutic plasma exchange for the patient along with the high dose corticosteroid. So just giving a brief idea of TTP. TTP is a rare life-threatening. It's in 1 to 3% per million population based on the geographical area. So it's a rare, but it's two types: immune and congenital. Immune is the most common and caused by the autoantibodies attacking the Adams setting, whereas congenital is rare, though it's a genetic mutation in that. So as Dr. Ashok sir previously mentioned, that predisposing conditions associated with the TTP, it's more than or equal to 60% is primary immune mediated. Others are which leads to TTP is autoimmune, infections, HIV especially, and congenital is rare. It's around 5% only, along with cancers, pregnancy, drug-induced, transplant, and others variant. So here in pregnancy, it is important to rule out if the patient is during the pregnancy to rule out the HELP syndrome as a first part on that, because it also shares the common pictures with the TMA, or we call it as MAHA. So as per the Oklahoma registry, how we can say the clinical presentation which is specific or which is particular to the TTP or MAHA. They are presented with the gastrointestinal symptoms in 69%. That is based on the Oklahoma registry of around 20 years registration of the patient. So weakness, most patients present with weakness initially, bleeding or purpura, initial stages. Major neurological findings, they are around 41%. What these studies are saying, even the patient is having thrombocytopenia, not severe thrombocytopenia, but neurological manifestation can present earlier before the thrombocytopenia. Minor neurological findings, 26%. Fever and chills goes from 10 to 30% around. And classical pentad, what we have seen in this patient is usually less than 5% in this registry. So coming pertaining to the ICU, the frequency of organ failure in ICU TTP non-hematological, mainly they are the non-hematological, is the CNS, which we can present with the severe disease like stroke, seizures, status epilepticus, coma. They can have 50 to 90%, though the studies, but different literatures are up to 50 to 90%. Acute kidney injury, especially in the ICU patient. When what happens in the ICU, sometimes that patient didn't get early diagnosis or get the delayed treatment, or because of the some reason they are not able to get the TPE. So 58% renal, in which in this particular study they find out 45% leading to the end stage renal disease. As Dr. Ashok sir already mentioned about the cardiac problems. So acute myocardial ACS can happen, congestive heart failure, cardiac arrest, elevated troponin, and ECG modifications like repolarization as the main ECG findings. But if it is present, it's a poor prognosis. It carries a poor prognosis. So we continued with our case. In view of drop in the sensorium, patient got intubated. MRI brain was done because the patient was irritable for 2 to 3 days. EEG was also advised for any subtle NCS presentation of NCS, but find out to be suggestive of diffuse encephalopathy. And MRI also doesn't show any significant apart from the metabolic encephalopathy in that part. At this point of time, I would like to ask Dr. Ashok sir, any specific testing at this point which helps to reach to making a diagnosis like other activities we do, just to confirm later on, may not be available initially, but to make a confirm of the confirmation for the TTP.
Yes, sir. As per the discussion, the patient is fitting, she's meeting all the criteria of pentad along with the cystocytes in the peripheral blood with normal coagulation parameters and cystocytes in the peripheral blood. So before going for plasma infusion, we requested our sisters in the ICU to keep an extra sample for ADAM-TS13 activity, sir. So if after giving plasma infusion, if you go for ADAM-TS13 activity, that may lead to a wrong diagnosis for us. So before giving plasma infusion itself, we should keep an extra sample to assess the ADAM-TS13 activity. That's what we did in this case. And the result you can show this.
Yes, sir. As you rightly said, it has to be done. Sample should be sent before the TPE, because as the plasma exchange you do, you supplement the Adams 13 factor along with your plasma. So just going brief in the TTP pathophysiology, what the Adams 13 deficiency can cause. In a normal person, ultra large 1 million factors, multimers, they cleaved by the Adams 13 in the shorter fractions. But what happens when there is deficiency of Adams 13? They keep circulating the large, ultra large volume multimers. They keep circulating in the blood, which ultimately leading to the platelet aggregation, hemolysis, organ dysfunction, causing ischemia to the brain and kidney, and carries a mortality about 10 to 20% despite treatment, as we discussed earlier. So how to deal with a situation here? In a journal, blood journal in 2025, there is a testing hemosil AccuStar CLIU through the thing. They said it's rapidly turnaround time is less than an hour. So if the turnaround time is less than an hour, so you can early have the Adams 13 activity and go on that part. What they say in their study also, they can avoid the unnecessary plasma exchange just based on the suspicion. If the plasma score is less, still the test has to be validated in the clinical settings. So this is just the researchers advocated for the hemosil AccuStar because of the less turnaround time. So as continued with our case on that. Karthik.
Yeah, one query here, sir, regarding the Adams 13, Dr. Avdesh was saying about the value. One thing is about the Adams 13 value. Does it hold any importance in your therapeutic management? Normally, all of us, like traditionally, we start tissue plasma exchange with steroids as a first line of therapy. But adjuvant therapies like Rituximab or Caplacizumab, do you base your clinical practice or usage of those agents basing on your ADAM level activity?
Usually, sir, predominantly it's not based on Adam TS13 activity, sir. It is that activity is very low. It is because of the antibodies, sir, immune mediated, no. So whatever Adam TS is there, that will be inhibited by these antibodies. So in order to reduce the relapse rates and also decrease the number of plasma exchanges, it will decrease the ICU admissions. So we have to add some drugs like Rituximab so that the antibody production will be reduced by killing the B cells. Steroids also by killing the T cells. So all this will have an additive effect in managing the patients of TTP, sir, along with plasma exchange. What plasma exchange will does is it will replace the antibodies present against the Adam TS13 activity and also replace and with the new plasma so that Adam TS13 activity will be restored. But if you stop that after once you reach the level of whenever you want to stop the plasma exchange, then again this antibody production will be coming again and reducing the Adam TS13 activity, leading to relapse. So in order to reduce that relapse, we have to start steroids and also Rituximab plus or minus Caplacizumab but this is not available in our country. We are going ahead with the steroid plus Rituximab, sir.
Yeah. So one more important point is what Sir said. Probably the Rituximab should be timed after your plasma exchange. Ideally, you should not be giving Rituximab before plasma exchange because it can be.
At least there should be a 4-hour gap, sir, between plasma exchange and Rituximab infusion, sir. Otherwise, that will be removed. Rituximab will be removed in the exchange.
Plasma exchange. And there is no role, sir. I was just in the literature, they have been mentioning regarding the activity levels. If it's less than 10%, then you can go upfront with Rituximab along with steroid and plasma exchange. But in your practice, you always practice Rituximab as an therapy along with steroid and plasma exchange, sir.
Yes, sir. According to guidelines, we have to go with this triplet regimen, sir. Plasma exchange, steroid, and Rituximab.
Okay. Okay. Yeah, Avdesh. Continue.
Okay. So yeah, as we said on 31st, the samples on third, it's almost around 4 or 5 days to turn around. So Adams 13 activity found to be having less than 0.2%. So it's almost negligible Adams 13 in her body. So as per this, we confirm the diagnosis of TTP. So management of TTP. So International Society on Thrombosis and Hematemesis, they have guidelines in 2025 recently framed for the treatment of TTP. So they have given therapeutic plasma exchange plus corticosteroid as a strongly recommendation, while for the Rituximab and Caplacizumab, they have given the conditional. Apart from this British Society of Hematology, they have given the grade 1A recommendation for the Caplacizumab, maybe based on his the mechanism, what it the functions, the way the Caplacizumab functions. So this is our case which followed on the 31st, continuing based on that what the treatment we have done and how we manages the case. So on 31st, we can see all the patient, this one severe anemia, thrombocytopenia, normal INR, serum creatinine is though it's 3.1, total bili indirect, LDH, and heptoglobin was done, which was undetected. PCT was found to be 1.15, anti-proBNP, it's around 4,000. So based on that, as we discussed, we started on the TPE based on the clinical findings, plasmic score, and the cystocytes present, along with the high dose steroid. So that was the first aid countess. As the days progresses, her clinical improvement, and she got extubated on the 2nd of January, where she received the third TPE and the steroid of the third dose, high dose steroid. So going over the platelets, the platelet recovery going on 0.25, plasma exchange was continued for 5th session, 6th session, 7th session, she reached around a lakh of platelets. On 8th session, it was 1 lakh plus. Plus on 9th, the sample, the testing was done on 8th, sorry. So it was showing around 1.5. So it will fulfill the criteria of the remission. We'll see in upcoming slides how it does. And the dose and the steroid was maintained as a maintenance dose around 2.5 mg per kg per day. LDH was also showed the improvement from 1500 to 600 to 400 to 250. It remains around 250's value. So that is also in the normal range. So two criteria which we normally see to stop the plasma exchange or to response to the plasma exchange. It's platelets and the LDH. And as Dr. Ashok sir said, this started on the Rituximab for the multimodal as a multimodal part of the therapy to prevent the remissions. So total 8 TP sessions was done for her, high dose steroid followed by maintenance dose and Rituximab. So this is the girl which she was presented in a condition where she was unaware of anything, landed up on the ventilator, severe thrombocytopenia, and this is the day on image on the day of discharge. So here we'll discuss the timing of the Rituximab as you already described in the part a little bit, and the Caplacizumab role in the TTP in a current scenario. Any further guidelines they are recommending for that, or it's just a bystander on that part? Dr. Ashok? Dr. Ashok?
Sir, currently in our country it's not available, but British Journal of Hematology, they advise to upfront they start whenever you diagnose a case of TTP, you should upfront start Caplacizumab instead of Rituximab. How it works means it's a monoclonal antibody which is directed against the A1 region of von Willebrand factor, so that it prevents the platelets binding to the GP1B receptor. As a result, platelet aggregation, all those microthrombi formation everything will be reduced. Once we start Caplacizumab, it is a 10 milligram dose. So once we start that Caplacizumab, what happens is it reduces the duration of thrombocytopenia, and also the admission duration, the number of PLEX procedures, that is plasma exchange procedures, and also the volume of the plasma used. All this can be reduced by Caplacizumab. But unfortunately, in our country, it's not available, sir.
Yes, so that has been recommended on that part, and we'll see few evidences for the recommendations and how it helps and the mechanism of actions. So how multimodal therapy works and their evidences. Multimodal therapy means in a TTP, you need to attack on the different pathological aspect. Like as plasma exchange, we replace the atoms, which is the deficiency, and remove the antibodies. So immunomodulator is Rituximab, which depletes the B20 cells, and corticosteroid also suppresses the antibodies. So this is the one mechanism of immunosuppression. And inhibitor of platelet 1 Willebrand factor interaction, that is the Caplacizumab. What it does, as Dr. says, it's a bivalent nano antibody which acts on the 1 Willebrand factor A domain. It attaches to that and avoids the platelet aggregation on that. So it doesn't allow on that part, and other supportive therapy which we already continue with our all as a supportive treatment in the ICUs. So going with the evidence, therapeutic plasma exchange, it was way back in 1991. It was proved that the therapeutic plasma.
I would like to make a small break here, Avdesh. There was one question by one of the attendees regarding the role of Eculizumab. So instead of Caplacizumab. So there have been 3 or 4 people who have been asking, and what is the role of Eculizumab? Sir, as far as I know, it is for atypical HUS.
Yes, sir.
Do you find an
HUS,
off-label
it is
indication for TTP?
TTP, there is no role according to the guidelines, sir, as of now. In 2023 also, there is an article from BJH saying there is no role of Eculizumab. But in HUS, definitely it is there. But unfortunately, that is also not available in our country and is very costly than plasma exchange.
So what happens in HUS? That's a complement activated. So Eculizumab work there. But what happens with the Caplacizumab? The primary pathology in the von Willebrand factor, where it attaches to the domain, A1 domain. So that's, I think it's not be interchangeable if even available also. That's mainly recommended for the and has not been given in the guidelines or in the evidences for the TTP because of the mechanism of action.
Yeah, and the second thing is about the role of antibody levels, sir. Do we have the availability of anti-factor H antibodies? And do we have, or we can have IgG levels of those antibodies? Do we have the test available? And how important is it for us to know about it?
Sir, usually we never even check whether it is available or not, sir. But because ADAMTS13 activities itself is only 1 or 2 labs in our country is doing, sir. Antibodies to ADAMTS13, I don't know whether they are doing it or not. So we never bothered for whether it is immune because we know more than 60% of the cases is immune mediated. We will be using the adequate immune suppression for quite period of time so that it will decrease the chance of relapse. But we never requested for the antibody levels to the ADAMTS13 activity. We don't know whether it is available also in our country.
Right, sir. Right, sir. So clinical parameters, then Adams level, and then antibody levels. We are like good to go with your clinical parameters per se, because it's an emergency situation, and the mortality worsens if you delay plasma exchange by more than 8 hours. Usually they say 4 to 8 hours is
48 hours.
after suspicion. Yeah, yeah. Yes, Avdesh, please carry on.
So, based on the evidences why therapeutic plasma exchange is the treatment of choice, that was shown back in 1991 by Rock et al. What he did, he comparison of the plasma exchange with plasma infusion. Before 1991, they used to be more of plasma infusions. As sir said, if not available, at least you can supplement some Adams 13 on that part, multimers. So what happens with the plasma infusion? The survival at 6 months is around 63%, but with the therapeutic plasma exchange is 78%. So it's significantly based on that part and the high survival. So therapeutic from that 1991 therapeutic plasma exchange become the treatment of choice for TTP. So how you do the therapeutic plasma exchange? Initiate within 4 to 8 hours. That's what we already discussed on part. Why it should be started early? As we said, time is life here. Each hour delay increases mortality by 1 to 2%, and 24 hours delay it increases mortality by 10 to 21%. Suppose 70% are the survival on that part. The almost if you delay, the chances of mortality is very high. How you do a plasma exchange? It's approximately 1 to 1.5 of the plasma volume you should replace with that part. And until when you need to continue? Until platelet count normalizes for 2 to 3 days plus LDH normalization. What is the case with our case? That's why we continued for the TPE for 8 days. In some condition, it has to be continued for maybe 10 days plus also if not improving on that part. Typically requires 5 to 10 days of treatment. So avoid platelet transfusion. Why? Because the pathophysiological mechanism, and Scully in 2009 in British Journal of Hematology, they documented increased mortality with inappropriate platelet transfusions. They say if only severe life-threatening hemorrhage you should consider. Otherwise, any deviation for that standard practice will increase the mortality of the patient. And as per the updated ISTH guidelines, they recommended for 1.5 plasma volume exchange for severe presentations. Again, the next treatment modality is the corticosteroid. So Baldwin in 2010, he did a study based on whether we use high dose or the standard dose. So this study proves to be shown have the superiority of high dose. High dose, that is 10 mg per kg per day for 3 days, which we did for our patient, followed by maintenance dose, which she was on. So what the study did find at the end of the day 23, 53 patient in standard dose group failed to achieve complete remission. It's important here is they do not achieve complete remission compared to the high dose 23%. It's other way. So what they resulted or they recommended is intensified immunosuppression with higher doses of steroid can reduce the rate of treatment failure and improve remission rates in the acute phase. So that's why we uses the TPE plus the corticosteroid of the patient based on this study. So again, the role of rituximab in the management of patient with TTP, as the studies and the literatures are coming and the studies are going on. So they recommended patient newly diagnosed with TTP frontline. Frontline means Plex plus corticosteroid plus rituximab. you can start all these things at a time. But as the Dr. Ashok sir said, if you are doing do the therapeutic plasma exchange as a first and wait for hours, and then you can start the rituximab. Again, it has a role in the refractory and relapse patient, plex plus corticosteroid plus rituximab. Patient in remission, maybe preemptive, you can use that rituximab, but some studies, they are against in the remission. So just Ashok sir, if you can put some light on this part, because in the remission, do we use it as a preemptive?
And the patient is in remission, no. So usually we start along with the plex, no. So
Okay.
weekly we give at least for 4 doses, sir. Once that is complete, patient usually go into remission, and then in follow-up we will measure the ADAM TS13 activity. Based on that, we take a call. Otherwise, no need to continue the rituximab beyond 4 doses.
So rituximab early integration for superior outcomes, that is, can be started after the plex also. What it does, mechanism of action is depletes B cell, which produces the ADAMS13 autoantibodies. The dose is the 375 mg per meter square for 4 weeks, initiated within first 3 days of the plasma exchange. You can initiate either day or within the first 3 days. What are the clinical benefits? It achieves, it decreases 67% relapse reduction compared to the plasma exchange alone, plus faster recovery, more rapid platelet normalization, and ADAMS13 restoration around 3.2 times. And in the long term, achieves the remission. And the guidelines are recommending at BSH and ISTH also recommending the Caplacizumab. So just a overview on the Caplacizumab. It's a anti-von Willebrand factor nanobody therapy. It works by blocking von Willebrand factor A1 domain, which preventing platelets addition to the large von Willebrand factor multimers and halting microvascular thrombosis immediately. Why it is added to be based on this, as the platelet recovery is there and it acts immediately. So it was also the upfront use in the TTP. Dose has already been discussed and continued for 30 days. Clinical impact is rapid recovery. Median days are 3 days versus 5 days, 3 days earlier than without the Caplacizumab. It reduces mortality. 74% reduction in the refractory diseases or relapse during the treatment period. So it's a big reduction, 74%, it's a big reduction. And the landmark trials which suggest is the Hercules and the other is the Titan. So what the Hercules says, it decreases 55% mortality here and recurrence in thromboembolic events because it's already halting the microvascular thrombosis immediately. In a separate study in 2021 Critical Care Medicine Journal, they also showed 40% reduction in the mechanical ventilatory days and 2.3 days shorter ICU stays if Caplacizumab has been used as an upfront medications. So these are the some, which is the Capla, this is the real-time, what they say is real-time data for the Caplacizumab used in immune-mediated TTP, multi-center study. What they did, they checked the probability of death from the time from first plasma exchange with Caplacizumab and no Caplacizumab. So you can see here that almost there is a decreased probability of that compared to without Caplacizumab. It's a significant proportion. And other what they did, again, the incidence of clinical response from the first plasma exchange with Caplacizumab and no Caplacizumab. So what they here that you can see it's a vertical improvement in the patient with the Caplacizumab, and without that it is there, but it's on the horizontal coming on, not so vertical as Caplacizumab. So it's also significant. Here it is, sorry, the third one graph is there. So they have that it becomes more vertical if you started as a upfront, means within 3 days of the plasma exchange. If you give within 3 days of the plasma exchange, the clinical response is much better compared to the second slide here. So now clinical decision making, when to initiate Caplacizumab in critically ill patients. As we discussed, any patient present with severe neurological involvement, cardiac manifestations, arrhythmias, heart failure, raised troponin, acute kidney injury, it means particularly increasing the creatinine and becoming oliguric and the requirement of the dialysis. Earlier platelet recovery may prevent progression to established AKI. Here, if you give it, it prevents the thrombosis and may prevent further kidney damage. And refractory recurrent TTP, they have also suggested for that one. So favoring Caplacizumab, if you have the atoms 13 less than 10% confirmed or multi-organ involvement, your plasmic score is more than 6. ICU level care is required for the patient. It's altered mental status or dialysis or cardiac part, or if any you see there is delayed PAX availability, because it immediately improves the platelet. So thrombosis is decreased, and I think that's leading to the organ improvement. Contraindication, it has one of the things is active major bleeding. Any patient if is having a major bleeding, because the one of the side effect is the bleeding by the Caplacizumab. Any recent surgery or trauma, any therapeutic, if the patient is on therapeutic anticoagulation for any DVT or for any reason, it's become a contraindication. It's a relative contraindication. If the life takes the priority, then it becomes relative. Otherwise, you have to be cautious. Any platelet count less than 20,000. So because that increases the risk of bleeding. Suppose if this patient is having 15,000 platelet, we will start the TPE. So we can delay for 2 to 3 days until the platelets improve. So on Caplacizumab, the expert recommendation is in critical ill patient with high clinical suspicion for TTP, that is plasmic score is more than 5, initiate Caplacizumab immediately after first plex without waiting for Adams 13 results. Mortality benefit greatest when started within 24 hours of presentation. So it's also advocated on the same day. If you have a diagnosis based on a clinical or plasmic score, so that's within 24 hours they are recommending. So once you have done the patient, started the treatment, you have diagnosed the TTP, started the treatment, therapeutic plasma exchange, or corticosteroid or Caplacizumab and all. So then how will you monitor? You daily do the laboratory monitoring of platelet, LDH, because these are the end targets of our improvement. Clinical response criteria, resolution of neurological symptoms, improvement in renal function, normalization of the hemolysis markers. And when you say complete remissions, when the platelets increases more than or more equal to or more than 1.5 lakhs, and it should be sustained for 48 hours, kind of. And Adams activity follow-up, how you do the activity follow-up, measure at the diagnosis when you started, as we did in our case, after plasma exchange cessation based on the partition, then at 3, 6, and 12 monthly. So activity more than, if in any during in these periods, if the activity comes more than 10% indicates remission. Anything activity which remains less than 20% suggests relapse risk. So there are more chances the patient will go into the relapse. And long-term surveillance, it's they say first you do inhibitor quarterly for first year, then biannually. Because why? Because if any decrease in the Adams 13 activity, you can intervene early. And Ben-Hamau et al. In 2020 established that persistent Adams activity less than 10% after initial response predict 80% relapse rate within 1 year, warranting preemptive Rituximab. But in our case, we have not yet done all things. Maybe we'll ask Dr. Ashok whether they are planning to do Adams 13 activity during the follow-up, or how they will follow up the this case.
Sir, in our routine OPD, we usually doesn't do ADAM-TS13 activity because it's very costly, sir. It is in OPD basis itself, it is almost like 30,000, and the report comes maybe after 1 week. So what we follow in our Indian setting is we routinely CBC, RFT, LFT, LFT conjugated or unconjugated hyperbilirubinemia, this one, and then LDH is the one thing, retic count is the other thing, and the smear to look for any cystocytes. If nothing is there, means we'll just follow up with these tests. Usually, we don't measure ADAM-TS13 activity just because of the cost constraints in our settings. Otherwise, these are the CBC, RFT, LFT, and LDH is the one thing. Other clinically, how she is behaving, how she is doing, like that we monitor. Along with this, lab test will help in long-term surveillance, sir.
Sure, sir. Thank you. And refractory and lapsed, this is the TTP advanced strategies. So what they say, if the patient is in refractory TTP, lack of response after 4 to 7 days. If suppose, for example, this patient would not have been responded 4 to 7 days. Then the strategy would be maybe increasing plasma exchange twice daily, add rituximab earlier. If not done, anyway, it was added on that part. Consider if not initiated, but as Dr. Ashok sir said, it's not available in India, so we don't have that option. As click 2 immunosuppression if persist. So I think that may be some possibility to give again high dose and wait for part. Second line immunosuppression, if for example she is become refractory to rituximab refractory cases, then these are the other options: cyclophosphamide and bortezomib. And relapse management. Relapse occurs in usually 30 to 50% within 10 years. So that's in half of the patient it get relapsed, but its time span is around 10 years. Defined as a recurrent thrombocytopenia with microangiopathic hemolytic anemia after initial remission. So the treatment remains again same: restart plasma exchange and rituximab immediately, add caplacizumab if available, and consider maintenance for rituximab. So yeah, so that will be concluding to our session for this presentation. Key takeaway messages. So what they say, it's modern. They added the word modern TTP management, which combines early recognition that we do, immediately triple therapy, start with the plasma exchange, caplacizumab plus rituximab, and vigilant for long term. This approach, when you go through this immediate triple therapy, that it increases 90% chances of survival and significantly reduces the relapse rate. Over to you, Karthik.
Yeah, so there's one question. Mostly, like in this case, we had neurological presentation, and we had one way the Adams 13 level less than 10%. So this was like a classical case of TTP variant of TMA. But many a times we might not have neurological presentations to guide us towards TTP. And you might be thinking about HUS and TTP overlap kind of situation. So if you are suspecting HUS, then what is your modality of treatment, and investigate the patient? Do you require the need for FH antibodies, and does it play any role in treatment of HUS?
Usually, sir, in TTP, if you ask, no CNS manifestations may be as low as mild headache to as bad as seizure activity, sir. So even if they have a mild headache, that you should take it as a CNS manifestation of TTP. Most of these patients will have, sir, something or other else in the form of as a CNS manifestation. HUS is entirely a different way of treatment modality, sir. Diagnosis will be different. Typical, atypical, Shiga toxin, non-Shiga, salmonella, all these things we have to take. And especially there, the role of dialysis or hemodiafiltration plays a major role than the plasma exchange, sir. And anti-factor H antibody levels, all those things, they play a major role rather than simple plasma exchange.
It's a diagnosis of exclusion, primarily
Yes,
HUS.
sir.
Yeah, so you have to rule out other etiologies, and then look for your Adams 13, the Adams level, or look for the Shiga toxin, and then if they are all negative, then you probably think of HUS and do for
And
your.
they have those manifestations. Even history will tell you whether it is more in favor of HUS or in the form or TTP. Diarrhea, abdomen, pain abdomen, all these things is more of a renal failure than CNS manifestations.
Right.
Yes, again, they said it's a varied presentation. Suppose a patient presenting with a stroke or the severe headache or seizures, as you said, plus with some thrombocytopenia, and anyone with AKI, again having little thrombocytopenia with a hemolytic anemia picture. And acute pancreatitis also, the case reports are that patient can have also presentation as acute, but so that's why the suspicion should be very high. So we should keep a very high suspicion.
Nowadays they say just microangiopathic hemolytic anemia and thrombocytopenia is there. Consider TTP as the one priority. First exclude TTP, then you can deal with any other condition, because this is the medical emergency. Rest of all the things are not that much.
Yeah,
It's a dreadful condition.
Yeah, most of the questions they are coming is how do you differentiate it if you don't have laboratory findings? Clinical findings may not always be very, very clear cut in presentations.
Then better to send a center where they have the laboratory. Because it's not a purely clinical, you need something in hand as well, apart from neurological, because neurological is a wide manifestations. Yeah.
You have any experience in gene deletion mutation for these HUS, sir? Have you any?
No, sir. No, sir.
Some of the participants were asking about gene mutation test. Do we do, and is there any role of it in HUS?
As of now, I never
Never.
asked. No, so no, we are not doing, sir.
Okay. Yeah, I think we have covered almost all the aspects of TTP. And today the whole discussion has been centric around first clinical suspicion. How do we suspect TTP? And once we have suspicion of TTP, the important point is to initiate treatment as soon as possible. And you have to monitor what are your monitoring goals, like your platelet improvement, organ function improvement, and reducing your LDH and microangiopathic hemolytic anemia. These things are going to be your takeaway points whenever you are having a case in your ICU of a TTP. So the first, it starts always with a clinical suspicion. That is where the primary interest and primary point that through this master class, we want to drive that point that always have a suspicion of TTP somewhere. So you might have thrombocytopenia conditions. There are many conditions which cause thrombocytopenia. It is always important that you always have TTP as one of your differentials because the treatment differs when in comparison to the other causes of thrombocytopenia.
One more
Sir,
thing I want to add, sir, here, Dr. Karthik, sir.
yes, sir.
Always keep it in mind that when you are suspecting TTP, don't give platelets. That is one more. Platelets, if you give, patient may die at any point of time, sir. We don't know, because this girl is a young lady. She survived, sorry, despite having 2 SDP transfusions.
Yeah.
Suppose he is like 40, 50-year-old, he might have died on the way itself.
Yeah, but mostly, sir, outside there is an assumption that with that kind of low platelets, patient might bleed somewhere. And second thing, when we are doing procedures and they are like compelled to give some platelets to, do the procedure.
In this condition, even the platelets are like 1,000, 2,000 also, sir. You can put a central line, you can put the dialysis sheet. No need for, in this case, if you see, sir, we have experienced, there is 3 lines we have changed just because of thrombus formation within the line, occluding the line. We had to change the line for 3 times in 3 consecutive days. So that it's a prothrombotic condition, sir. Especially TTP is a prothrombotic condition. So once the platelets are more than 50,000, either we have to give either low molecular weight heparin or just aspirin. They say aspirin. More BGH guidelines say aspirin when the platelets have increased more than 50,000, as aspirin 75 milligram per day will help in reducing that prothrombotic tendency.
Thrombotic. Yes, sir. That is one more point, important point that you have mentioned about anticoagulation and antiplatelets in thrombocytopenia. When we mostly miss this point, rightly said, sir. So we'll see some some questions from the attendees who were asking. I'll try to put up this question to Dr. Avdesh and Dr. Ashok. So, why was Coombs test in this case positive? Could it be an overlap with TTP
The
and
antibodies against ADAMTS13 is also IgG, sir. There may be, in what we are testing in Coombs is also IgG. So there may be cross reactions, sir.
cross reaction, false positive?
Usually TTP, Coombs should be negative, sir.
Correct.
And what is in some 2 to 3% of cases, it can be become positive. But as the sir said, that's the reason is maybe the cross reactivity on the or the RBC destruction itself on that. Yes.
Okay. And plex therapy, sir. There are many questions on plex therapy, whether you would prefer to do a daily plex or an alternate day plex. And weaning off of plex, we have already mentioned you need 48 hours of stabilizing platelets with 1.5 lakh at least for 48 hours. You need to hold without fall. That would be our end point of doing plex. That is why we have done here in this patient for 8 days, and a gradual decrease of LDH being seen with consecutive plex therapy. Daily plex versus alternate plex, sir. Do you think it's a
As far as the guidelines say, we have to go do daily plasma exchange until the platelet count more than 1.5 lakhs and LDH normalizes. Suppose even after
Because
7
if you,
sessions of plasma exchange also there is no increment in the platelet count or no fall in LDH, then we label it as refractory TTP. In that case, we have to go for twice in a day also we have to do plasma exchange, morning and evening sessions. Almost
Right.
like so that will help in improving the platelet count, sir. And in previously we have done like that also twice in a day. One patient was not improving even after 7 days of plasma exchange. So we have changed to twice daily plasma exchange. Along with we started cyclosporin also in order to get good immune suppression. Then the patient started improving the platelet count and then a fall in LDH. So that is called refractory, which is very bad, and the mortality is very high. Fortunately, that lady also survived, and she came last in this January 1st to say greetings for us and gave some chocolates also to and wished us also. So after 4 years, she is still there without any immune suppression and without any further relapses also, sir. She is almost like a cure only.
Yeah, that's great, sir. Yeah, so I think we have answered most of the questions that have been asked, and we have elaborately.
There is one more question. Low volume or normal volume plex. Usually, sir, plex it should be done at least in first 3 days. It should be very aggressive. At least 1.5 volumes of plasma exchange we had to do. Then once the patient started improving, we can reduce it to 1. There is no nothing like low volume or normal volume plasma exchange like that.
yeah, because ISST recommendation is also go with the 1.5 volumes.
Yes, and more important is that here we prefer to use more of plasma as a substituent for replacing. This is one of those indications where plasma is used. Mostly nowadays, plex therapies, when we are moving towards doing with 100% albumin. Now, this is one condition where we have to be very, very cautious
The
about.
albumin will not replace that ADAMTS13 activity, right, sir? Here,
Yeah,
the
here it
entire
won't help, sir.
pathophysiology is different, no? So we have to replace only with plasma. Day
Yes, sir.
one, we have started here like that only, sir. Then I requested our transfusion medicine, Dr. Nandakishore, sir, to do with
Yes,
FFP only.
yes, sir.
Yeah.
Right,
Yeah,
sir.
because in
So
this TTP purpose is to remove the antibodies and replace the TTP.
ADAMTS13.
Adams 13. It can't be done with the albumin or other things. So purely plasma only.
Yes, sir.
So I think with those remarks, I think we come to the end of the session, sir. Today it was a very, very informative session, sir. And I would like to thank you for taking out your valuable time and spending with us on today's webinar. And with this discussion, I'm sure many people who have heard to this webinar would have learned a lot and would carry home the key points that you had suggested and we have discussed in this case. And Yashoda Hospital brings every Tuesday such interesting case discussions wherein we call experts who are in their own branches have been doing well and catering to many of those complex cases and sharing their valuable experience with us. And with these remarks, I would even like to thank Dr. Avdesh for preparing such a eloquent case summary and presenting it in a very, very interesting way so that the discussion went smoothly forward. Thank you all, and thank you, Venkat sir, for joining an introduction. And we'll meet again on another Tuesday evening with another interesting topic. Thank you, sir.
Thank you very much, sir. Thank you very much for giving this opportunity.
Thank you, sir, for the opportunity.